So these are tumors that are considerations. The ones in red are ones that I have treated in the past. It is quite a list. So there are a lot of things that we can do. A lot of these humans would not do. Mostly they do non-melanoma skin cancer, so basal cell and squamous cell are probably the most common that they treat in humans. But there's lots of other things that we can do. This is in our CT room. You can see Danny, my nurse, and myself with one of our patients and the unit to the left. This was a palliative attempt, intranasal adenocarcinoma in a very healthy cat. You can see the swelling over the nose. It had broken through the nasal bone, was bothering the eye. The eye was starting to be almost shut completely. So the owners asked us to do some palliative. You can see how I angled the beam to try to get through the hole in the bone. And I was able to use a small cone and stay away from everything else. And again, we did put a shield in that eye. That swelling completely resolved, and we're waiting to see if anything comes back. We're using a anti-angiogenesis protocol to try to slow down recurrence. Another oral melanoma. This was more of trying to really knock this tumor back. It had regrown after surgery. Owners did not want to do a jaw excision, so they asked us to treat it. And that picture you see, I think we had done 2 or 3 of the treatments. It was very red and proliferative before and bleeding, and now you can see it's pink, and it regressed probably by then, probably 40 to 50%. This was a very ugly tumor, histiocytic sarcoma growing on this dog's foot. They initially thought that it was a plasmacytoma, could not really get a diagnosis more than a round cell tumor. When it came to us, it already had a big superficial cervical node, and we were able to make a cytologic diagnosis of histiocytic sarcoma on an aspirate from that node. Now this tumor was pretty big, was bleeding. So the owners wanted some palliative treatment there, even though we had started lomustine chemotherapy. By the time we saw the second time, the node had completely gone away, which clearly must have been the lomustine. And in order to do the planning the first time, I actually had to treat a bilateral treatment, bilateral opposed, where I treated from the top and the bottom. And again, the program allows you to do a bilateral opposed, but I was treating with the full 8 gray, both top and bottom. Again, I made sure I was right over the tumor and not giving any area a double dose of radiation. By the time it came back, which is a lower picture on the left, most of the tumor on the top had died off, and it was much thinner. You can see what it looks like. So I was able to rotate the foot up and then just use 8 gray at 100 kV directly from the palmar surface. And hopefully we will continue to see regression between the radiation and the chemotherapy. Dog was much more comfortable even after the first treatment.